editor at Journal of Mood Disorders.
Thank you. Thank you for this introduction. I'll be talking about maintenance ECT in clinical practice. I have such limited time, and I also have 51 slides. I thought I would have more time to deliver my presentation, but unfortunately that is not the case. Now, let's now talk about maintenance ECT. I'm going to talk about maintenance ECT practice and also talk about special patient groups. I will look at studies that have been conducted and the treatment guidelines and ECT in these guidelines, patient satisfaction, and what we do as Gaziantep University Hospital ECT unit, and then I will offer you my conclusions before I wrap up. Now, in the post-ECT process, when the patient is on remission, when the patient's condition is improving, the ECTs that you administer to the patient are called maintenance ECTs. There are a couple of different perspectives. APA says that if you do it in the first 6 months, this is continuum ECT. If you do it after 6 months, then this is entitled maintenance ECT. But in the literature, actually continuum ECT and maintenance ECT and continuum ECT are interchangeable, so the lines are not clearly cut. ECT used for the schizophrenia patients, schizophrenia came to be used in other disorders as well, for major depression as a first-line treatment. If there is no resistance, you get a 70 to 90% of response. But in refractory patients, this regresses down to 40 to 60%. For maintenance ECT, what's important is as follows. Yes, it's a very potent treatment. You do it 3 times a week. It's quite speedy. But after that, after the regression of acute symptoms, you discontinue ECT. But what happens afterwards? Actually, for major depression, relapse rate is 80% within the first 6 months. That's why you need maintenance therapy. So actually, we continue prophylaxis for these patients, and we give them antidepressants during ECT or mood stabilizers or antipsychotics. But when you discontinue ECT, relapse rates are increased. So in maintenance ECT, can we find a prophylactic solution to our problem? I will try to answer this question. Prophylactic ECT therapy coupled with medications is more efficacious than medications alone. So we will put the patient on maintenance. Patients get this maintenance ECT. For how long should we put the patient on maintenance ECT, and when should we start this treatment? Kanmat, Mahmoud has left us, but because he has to be in the other hall, he's going to present there also. CanMat indications for ECT as a first-line therapy are listed here, so let me skip these parts. In 2001, APA published an indication for ECT, and this is what is said. In the acute phase, and if during relapse, if medication fails, then ECT should be chosen. If medication treatment is not safe due to comorbidities, or if the patient personally prefers ECT, then maintenance ECT should be considered. And also, in maintenance ECT, how long are we going to continue this? Every 6 months we need to assess the patient and decide whether we should continue the ECT or not. Maintenance ECT is effective, it's safe, it reduces hospitalizations and recurrence in elderly patients as well. Maintenance ECT has an impact on resistant and recurrent mood disorders. Now, the other speakers touched upon maintenance ECT. For how long the patient should be on maintenance ECT. We all have these question marks, and we need to we need to find answers to these questions. And actually what we think we need is an algorithm. I'm sure you're familiar with the concept. There's the stable algorithm here. And one of the most important things here is this. We don't need to apply this to each and every patient necessarily. The patient's conditions should be taken into account when determining the scope of maintenance ECT. During the first 4 weeks, a fixed ECT period should be monitored and applied. 2 ECTs during the first week, and we actually do 3 ECTs on Mondays, Wednesdays and Fridays at our clinic. And then if we are going to put the patient on maintenance ECT, then we get together as a council and discuss the patient, discuss the case, and then for 1 week we reduce it down to 2, and then what is recommended is this: 1 ECT per week for 2 weeks, and then in the remaining period, remaining 10 days, 1 ECT per week, and 4 ECTs in 4 weeks, and then the remaining sessions should be titrated based on the patient, which means if the patient, this is for depression by the way, if on the Hamilton depression scale, if the patient is lower than 6, then during the weekly assessments, you do this assessment before the ECT. If it's lower than 6, ECT can be skipped for that week. Or if during the previous session, if the score, if the increase is lower than 3, then the session can be skipped and the patient can be assessed the next week. If this elevation is between 3 and 8, you should stick to 1 ECT per week for 24 weeks, by the way. And if the difference is between 8 and 16, if that is the extent of the elevation, then you should stick to 2 ECTs per week. But you shouldn't continue that for more than 3 weeks, twice a week that is, and if necessary continue with once a week. Also, another caveat is the following. These patients also suffer from cognitive losses, and delirium is also seen quite a lot in these patients, so we need to be careful about that as well. Stable algorithm. Does it really work? This was tested by a group. This is a retrospective study. It was tested whether the algorithm really works. In all of the patients, it was seen that, it was observed that if stable had been applied on these patients, relapses would be predicted 2.2 weeks prior to the incident, and for 20% of the patients they realized that there was excessive ECT. Special patient groups and ECT, in all 12 in this journal there was a compilation, and I will try to give you some information about this. All of these studies are about depression. The first 2 are randomized controlled studies, so let me begin with them and then take a look at naturistic and prospective studies. The first one is the core study. There are 201 patients here. That's the cohort. They are separated into 2 arms. One gets maintenance ECT, the other group gets nortriptyline, 103 patients. So what happens is the patients receive 10 sessions of ECT, and 4 of them are once a week, the remaining 4 every 2 weeks, remaining once a month. In total, 10 ECT sessions. And there is no significant difference in terms of remission, in terms of between remission and the medication arm. And as for the average relapse, again, there is no marked difference. Well, there is a slight difference here, but it's not significant on a statistical scale. Yet another study is based on 33 psychotic elderly patients, single blind randomized controlled studies. 16 of the patients received nortriptyl and ECT. The remaining 17 only received nortriptyl. Relapses, recurrences are checked for over a period of 2 years. The first arm has a 60% recurrent, the others 47%. As for survival, 23 months in the medication only arm, 16 months in terms of cognitive and cardiological side effects. There is no difference. In terms of safety as well, there is no difference either, especially for elderly patients. This is important. Second group, naturalistic or retrospective studies. There's a prospective study here. 24 patients get ECT. Maintenance ECT arm has 11 patients. Medication arm 13 patients. The patients are followed up on for 1 year. At the end of the year, one person in the maintenance ECT has relapsed. In the medication arm, 3 people have relapses. But in the study, it doesn't say whether there's a difference between these two groups. Another study, 53 elderly patients, MECT, follow-up 2 years. Total number of ECTs, on average, 11.8, which is rather low. But despite this, there's a 53% decrease in going to the hospital. And as for hospitalization, there's a 79% decline in these patients when there's MECT. Another retrospective study, 19 major depression patients are taken, and the MECT period is about 26 months, and average number of ECTs is 37. Follow-up is 4 years, and hospitalization stay, duration of stay is reduced significantly. And bed occupation compared to before the ECT, there is a significant decline. Once the MECT is discontinued, there is still a reduction. Another retrospective study reveals the following results. 25 major depression patients, patient-adjusted ECT sessions. In the previous studies there was a fixed setup, but this one is patient-specific. And 3 years, the follow-up period is 3 years before MECT, 3 years before MECT, 3 years after. And number of duration of stay is reduced by 76%. Unfortunately, your last 2 minutes. I have yet to come to the half of my presentation, so maybe I should just skip this. So, combination of MECT and medication and MECT only has not been compared yet, and that's why we don't know whether medication use has an impact on MECT. Bipolar patients, let's focus on MECT for these patients. There is one study that I would like to share with you. 14 patients were checked, MECT once a week, then once every 2 months, and then 6 months after 6 months of well-being, ECT is discontinued. This is how the protocol was drawn up. All the patients were benefited. These are fast cycle, rapid cycle patients. And before the ECT, the patients had 6 episodes. During the MECT, during the 2-year follow-up, 58% of the patients did not experience any episodes whatsoever, and 42% of the patients only had 1 episode. Compared to the past, this is rather substantial. Again, in terms of length of stay, and the results are much better. In schizophrenia, there's one study I wanted to share with you. 45 schizophrenic patients divided into 3 categories. One receives MECT, flupentixol, one only MECT, another group only flupentixol, and follow-up is 6 months. Relapse rates are 40 for the first arm, and for the others it's almost as high as 100%. As for Parkinson's disease, ECT might prove beneficial according to certain studies. In our clinical practice as well, we have a publication, 3 cases I brought with me, and in the acute phase and maintenance phase as well. And by the way, this is still a part of our maintenance therapy. We do have a Parkinson's disease with a bipolar diagnosis. In dementia as well, there are certain studies. In elderly patients, major depression increases morbidity and mortality, and vice versa. And in one of these studies, 58 patients above the age of 65 were checked. They were given MECT, and it was found that hospitalizations were reduced significantly thanks to MECT. In adolescents, there are certain studies. In pregnant patients, Feridun covered this, so let me skip this also. Drug interactions. There are a couple of things that we need to be careful about, especially in bipolar patients. Valproic acid, lamotrigine are agents that we use, and especially these increase the epileptic threshold of the patients. And for these patients, the benefits might be limited compared to the other patients for MECT. And also use of benzodiazepines are quite tricky. Well, at this stage the patients are very satisfied. This is also a study on bipolar patients. This is another study on ECT. The patients are quite happy with the treatment. It's almost 15 out of 12, and they want to continue the treatment. So how about the period after MECT? We don't have enough information in the guides. 45 patients were followed up for 1 year after ECT in one study, and during the first 8 months, 20 patients had relapse, especially during the first 3 months. So when we follow up on these patients, we need to focus on the first 3 months. So what do we do as Gaziantep University? We try to publish as many articles as possible about these topics, and we are interested in MECT, and we are currently writing an article, and there are 17 active MECT patients at our clinic. Most of these are bipolar patients, and 3 of these patients also had catatonia, and that's when we first saw the patients, they were catatonic, and then mania followed suit. 3 major depression patients, and we had 2 pregnant patients as well, if I'm not mistaken. 3 major depression, as I said, 1 schizoaffective, 1 schizophrenia, 1 psychotic disorder, 1 Parkinson's disease, accompanied by bipolar disease. Thank you.